and always a combination of the primary hormone coming out of the gland. In the case of thyroid, it will be T4, and the controlling hormone, which is TSH, are always assessed together. And always there is an inverse relationship between the two. So if T4 goes low, the TSH goes high, and if the T4 goes high, the TSH goes low. As a corollary, if you take the ovary, which secretes estrogen, if the estrogen goes low, the corresponding controlling hormone, which is FSH, goes high. And if the estradiol goes high, the FSH will go low. As if, let's say an example, we are supplementing estrogen from outside, you will see a decrease in FSH. In the case of adrenal, if the adrenal is failing, you will see that the cortisol will go low, but the corresponding controlling hormone, which is ACTH, will go high. So there is always an inverse relationship between the two, because there is a very specific servo control relationship between the two. So T4 going high or low will always affect the hypothalamus and pituitary and will change the controlling hormone accordingly. So it's very important that you assess both these together. You cannot just say that T4 is low or high and therefore the person is hypo or hyperthyroid unless you do TSH and show that it is correspondingly abnormal. So this is one very important point in the management of any endocrine disorders, and a lot of mistakes are actually made here. I presented a case which was frank, which means that if you look at the spectrum of thyroid disease, on one hand, what we considered today was frank hypothyroidism. Typical symptoms, very low T4, very high TSH. And on the other hand of the spectrum, we have thyrotoxicosis, which has a very high T4, but a very low TSH. So these are extremes and they have very typical symptoms. But if you look at the spectrum, you will always have mild cases of hypothyroidism, where both the T4 and TSH are mildly abnormal. And then, of course, you have this mid category where everything is normal and there is euthyroidism. It's mostly in these mild categories where things have started to become slightly abnormal are most mistakes made. In the frank categories, the diagnosis is often very clear. One has to also remember that all hormones in the body are not circulating in the free form, because hormones are very highly active chemicals. And if they are just allowed to circulate in the circulation, but without being bound to anything, they will just go and attach to the target organs and start producing their effect. The body doesn't need that. The body doesn't want that either. So what it does is, it binds these hormones to specific carrier proteins. In the case of thyroid, this is thyroid binding globulin. So when you assess T4 in a laboratory, what you're actually assessing is T4 bound to thyroid binding globulin. Okay, this is the bound form. And when it goes to the target organ, the T4 dissociates from the thyroid binding globulin and gets converted into the free form, which is called free T4. Now, why is this important? It is important because there are many non-thyroidal illnesses which can change the binding protein. Some raise it, some lower it. So obviously, non-thyroid disorders which raise TBG, if you do a T4, you will find that it is spuriously high. In those conditions where the TBG goes down, the T4 will be spuriously low. But remember that these people do not have actually thyroid disorders. So their TSH remains normal. So therefore, to avoid this kind of confusion, instead of measuring T4, which is dependent on the thyroid binding globulin, we measure what is called free T4, which is the active hormone. And therefore, it is not influenced by many of these disorders, and you get the correct picture. So typically, we ask for FT4 and TSH, or free T4 and TSH. Now, what are the common causes of hypothyroidism? The commonest cause of thyroid disease is always autoimmune. Remember that. And therefore, unless and until we are, in a doubt as to whether it is something else, it is assumed to be autoimmune. So 95% plus of cases are actually autoimmune in origin. There could be some other diseases, like, for example, the patient has had thyroid surgery for something, or the patient has received neck radiation for some other cancers, and that is a non-autoimmune disorder. But by and large, unless this history is present, you can assume that this is autoimmune. What I would like to point out is that we know that iodine deficiency causes hypothyroidism in endemic areas. So the hilly areas in certain parts of India, and we know that as endemic goiter, and it also causes cretinism. But remember that iodine excess also causes hypothyroidism, and this is something which people often do not recognize, and I'll come to this later through a case subsequently. Now, what do we do for such patients? In patients who are otherwise healthy, less than 60 years of age, and do not have major unstable coronary symptoms, this is important. You start with the full replacement dose of 1.7 micrograms per kilogram per day. So very often I find that there is a bit of a hesitancy in starting the correct dose, and people start with 12.5 and then wait for a couple of months, then increase to 25. This takes too much time. The patient remains symptomatic. So if you are convinced that this patient has frank hypothyroidism, look at his weight or her weight, multiplied by 1.6 or 1.7, calculate the dose. It could be more than 100 also, depending on the weight, and start immediately the thyroid treatment. However, if you find that the patient is elderly, more than 60, has some active coronary disease, you can start with 20 to 30% less dose, see that he's tolerating the dose, and then maybe step up the dose after 6 to 8 weeks. So it's important to calculate the dose. You cannot arbitrarily start with 25 or 50. Well, you could, but then it would take a long time for them to get controlled. I'm not currently discussing congenital and pediatric hypothyroidism. What is very, very important is the maintenance. And I again often see a lot of mistakes which are done here. And many of my patients come to me just for this because they've been started on thyroxine and the doses are continuously being changed. That is not actually correct. And I'll show you an algorithm which explains this very specifically. What is our target? Our target generally, which means what is the optimal level that we need to consider? We need to TSH to be between 0.5 and 2. As you can notice here, I'm not talking of T3 and T4. They are immaterial because of the first graph that I showed you, which says that for any X change in T4, there is a 10X change in TSH. It's that sensitive. So then, if you're even minutely over or underdosing with thyroxine hormone, which is the T4 hormone, you will immediately see changes in TSH. So you don't really need to monitor T4. What you need to monitor is TSH, and we need to keep it between 0.5 and 2. We shouldn't go below 0.5, and roughly a good thing is to keep it around 2 to 2.5. Understand what we really do. And this is where the mistakes come up. So let's say we started with initial thyroxine dose, whatever it was. You repeated the TSH. The TSH comes to 0.5 to 2. Now, what is done here typically is that people start to reduce the thyroxine because now it has come to normal. Either they stop it or they reduce it. No, this is the dose which is keeping your TSH normal. This is ultimately replacement therapy. We are not trying to cure the thyroid. We are replacing what is deficient. And therefore, if you continue the correct dose, the TSH will remain normal. And if the dose is correct, you don't need to do anything. Just call the patient back after 6 months. If the TSH is still normal, call them back every year. If, however, you find that the TSH is not in target, you could change the dose. but always remember to do it by very small increments or decrements. Again, the common mistake is if the TSH has come normal on say 100, the dose is suddenly reduced to 25. That is not correct because 100 is the dose which is keeping your TSH normal. 25 will not. So again, next time when you check it, it will become high. Then the patient is put on 150 because it's high. Then it will go very low. Then again, it is reduced to 25. And this cycle goes on endlessly. So remember, the dose of thyroxine is the dose which keeps your TSH normal. Whether it is 100, whether it is 150, whether it is 500 is immaterial because the body has such a sensitive system that it will not allow even the minutest overdosing. So in this patient was started on 100 micrograms. She took the tablet daily after lunch and then 3 months later reported for follow-up. She says she is better than before, but when you check the TSH was 7.3. What next? So basically here now we are talking about factors which reduce levothyroxine effectiveness. Why? Because you have started the correct dose and yet the TSH has not come into normal. Now, what do we see in such situations? The first important thing that we see is compliance. Check whether this patient is actually taking the dose every day. And to make sure, see, the patient needs 7 tablets a week, right? So tell the patient that if she misses on a particular day, she takes a compensatory increase in dose on the second day. That means she takes 2 tablets on the next day. One important thing that has been missed is she was taking the dose after lunch. If you take medicine after food, the absorption of thyroxine goes down by almost 30%. The dose was correct, but the timing was wrong. Correct the timing, and you will often get the TSH right. Apart from these 2 important things, the other things that can cause the dose to be higher than usual is when there is malabsorption. It could be because of past GI surgeries. It could be because of celiac disease. It could be because of drugs. And these drugs are very important. And the commonest drug which changes thyroxine absorption is iron. So remember to actually check whether the patient is on simultaneous iron therapy. And then there are drugs which increase the clearance of thyroxine. And again, these are very commonly used drugs. They're typically anticonvulsants like phenytoin and carbamazepine and antituberculars like rifampicin. I'm not going to go into amiodarone right now, but remember that these things, so look for drugs, look for timing, look for compliance, and look for malabsorption. So malabsorption history is pretty obvious. Patient has GI symptoms, frequent diarrhea, and there may be other vitamin deficiencies. There could be low cholesterol, low vitamin D, and so on. So in our patient, the problem was actually the timing. She needed to get it before her breakfast on an empty stomach, not eat for half an hour, and then go ahead. Let's take case number 2. And now this is not as overt as what we saw. This is again a situation which we come across very frequently now because so many people do these kinds of testing very often. This is a 35-year-old male executive, busy, does not exercise regularly, frequent tours, business lunches, dinners, gaining weight, feels short of breath. He already has mild elevation of sugars. The triglycerides are high. You can see that the SGPT is little high. Frequent dinners, frequent alcohol has pushed up his uric acid. And as is nowadays the common practice, thyroid is also included in these screenings. And you will see here that the T3 is normal, 97. T4 is 7.2. But the TSH, which normally is between 0.5 to 4.5 in a usual population, is 6.6. This gentleman weighed 85 kilos. He went back to the executive check package center and bang, he was told, look, you have hypothyroidism. And he was started on 200 micrograms of thyroxine because he's overweight. Now, remember that here we are dealing with a mild elevation of TSH. And Somebody asked him to do the free T4 as well, because I had said that you must do the FT4, but the FT4 also was normal. Now, what are we dealing with here, honestly? And this is a situation where the free T4 is normal, but the TSH is slightly high, more than 4. And this patient, we call this subclinical hypothyroidism. Now, when I say subclinical hypothyroidism, I mean that this patient does not necessarily have any symptoms related to his thyroid disease. Now, if you go back to his symptoms, what are his symptoms? His symptoms are actually progressive weight gain and shortness of breath. Now, can you believe that a TSH, which is mildly elevated, can cause all this weight gain of 85 kilos? It's impossible. It's like saying that if your normal fasting sugar is 100 and your sugar is 104, you will go into a coma and you will start him on insulin. It is that ridiculous. So yes, it is borderline. We will decide what to do about it. But to ascribe everything to this TSH is something which is very, very disheartening and maddening. So this subclinical hypothyroidism you will come across every now and then. It's a very common entity, and up to 7% of people in the general population have mildly raised TSH. The incidence increases with age. And if you find people above the age of 65 with mild TSH elevations, it is actually normal. So elderly people, TSH of up to 6.5 or 7 is completely normal. Now, there are a lot of controversies regarding the significance of this so-called mild subclinical hypothyroidism. Some say that even mild TSH elevation will be leading to high LDL and CAD. It's partly true. So what we do is that if the patient has a very strong history of coronary artery disease, has multiple risk factors, and has an elevated cholesterol, and has other factors for coronary artery disease, well, you may be partly justified in treating this TSH. But in otherwise young asymptomatic individuals, it doesn't matter. The other area where you will definitely treat even if no symptoms is a young woman who is planning to bear children, because in pregnancy, a abnormal TSH is not something which we want. I don't know if this slide is very clear, but this is the algorithm that we use. So what do we do in such patients? One thing to do is not do anything. Just tell the patient to modify his lifestyle, start exercising, dieting, change his food habits, reduce his alcohol, etc. And you will find that he has lost weight, his shortness of breath has gone away, and the TSH is either stable or it may even come down. But if you're so interested, you may also do anti-thyroid peroxidase antibodies. So this is a marker of autoimmunity of the thyroid. Now, what is the logic? The logic is that if anti-thyroid antibodies are significantly elevated, and if the TSH is also elevated, the chance that this will progress to overt hypothyroidism is 50% in the next 5 years. So if this person had a very highly elevated antibody and the TSH is high, yes, you may be justified in treating with thyroxine. It may not cause any medical difference to him right now, but yes, you may be justified. But if the thyroid antibodies are negative, wait, there is no hurry to treat till TSH is crossing 10. Remember that always. If, however, you feel that some of his symptoms are actually related to thyroid, and that is an individual call by assessing the patient, you may give a 3-month trial of thyroxine. If he improves, you may continue thyroxine. If he doesn't, just ask him to follow up annually. And generally, by and large, if no symptoms, antibody negative, and TSH less than 10, just follow this patient annually. Don't be in a hurry to start treatment, because if you start treatment, everything will be blamed on thyroid later on. Let's take, that is about subclinical hypothyroidism. Be very careful of stamping this patient and starting therapy. Now let's take another example. This is a 43-year-old female. She has sought your help for progressive weight gain of 10 kilos. Her biochemistry is normal. Sugars, lipids, HGPT, creatinine, everything is normal. His blood pressure is normal. Look at the TSH. It's 3.1. And somebody said, no, but I think 2.5 is normal. 3 is very high for you and you're gaining weight. Let's start you on thyroxine. Now, the patient also very readily agrees because she wanted some therapy for her weight. Obviously, no change in weight was occurred because she was just taking thyroxine. And because she didn't lose weight, the dose was increased to 100. And then she came to me. The TSH was very, very low, 0.06. Of course, there were no symptoms, but the TSH had dropped and the weight was the same. What is the problem here? The problem is that you're linking obesity and thyroid. And the real question is, are the two linked to each other? It is very, very important to answer this question. And the second important thing to answer is, does therapy for thyroid really influence weight and fat mass? These are two very important questions which we need to answer. Understand that one expects only a small loss in weight with treatment. So let's say your starting weight was 60 and the patient developed hypothyroidism. You started treatment. The weight will come back only to 60. It will not go down to 50. This is not a weight loss therapy. And a lot of this weight loss is actually due to the loss of salt and water, which is accumulated due to hypothyroidism. After that, people believe that it should still continue to cause weight loss. That will never occur. And once euthyroidism is achieved, that means the TSH is normal, the ability to gain and lose weight is the same as in people who do not have thyroid problems. So I get people coming to me, they're hypothyroid, they're taking thyroxine, their TSH is normal, and they say, no, but I've been told that because I'm hypothyroid, I'm not losing weight. How can that happen? You're already on treatment. Your levels are normal. So now these people will still, despite being hypothyroid, will continue to require lifestyle modification. So don't use thyroxine as a weight loss tablet. Can thyroid hormone be used to lose weight, as was done in our patient, which we just saw? Well, if you use, say, 800 micrograms of 1000 micrograms, yes, there will be some weight loss. But what is the weight loss due to? It is because of protein and bone loss. There will be some fat loss as well, but most of it is actually lean body mass, and that is not what you want. So clearly, and just imagine a thyrotoxic patient. The patient is feeling so weak and run down and debilitated. That's because his lean body mass is going down. So this is not what you are expecting with thyroid treatment. And what I want to point out is that TSH level itself in obese people. So the typical thing is to do a TSH because you're obese, and the TSH will come borderline high. And this TSH is not the cause of obesity, but it is the result of obesity. And why? Because in obesity, leptin levels increases. Leptin modifies the hypothalamic-pituitary-thyroid axis and marginally increases TSH. So borderline TSH levels, as we saw in our patient who was obese, is often due to obesity and not the cause of obesity. Please remember this very specifically. Let's take another case. Young girl born and brought up in Nashik, had a stable size goiter for several years. I saw her repeatedly. Her TSH antibody titers were repeatedly normal. She had a small goiter. No, it's not very great. And the parents were keen to treat her and also were asking me about any dietary changes. They said they have heard so much about cabbage and all kinds of things, soya, etc., etc. Let me clear the air that excessive amount of what are called cruciferous vegetables like yellow turnips, cabbage, cauliflower are considered goitrogens in very large quantities, when used in very large quantities. But that is only in areas which have severe iodine deficiency. In our state, where there is no iodine deficiency, particularly in areas where we live, there is no role of restricting these foods in the amount that we normally eat. So if somebody is eating cabbage day in, day out, that's a different story. But in the way we normally eat, there is no dietary intervention that is needed. These patients' relatives were not very happy with what I said. And they went to someone. Apparently, she came back to me in 6 months' time. And now actually the goiter is large and the TSH is now 26. And I was wondering why the TSH suddenly went up in 6 months' time. The antibody titer was still negative. So I asked, are you taking any therapy? They said, because you didn't offer any therapy, we went to a ENT surgeon. He said, I'll treat this. And he gave her some medication. Can anyone guess what medicines were given? If someone wants to take a guess, he or she can unmute and quickly give me an answer if you want to take a call. Okay, I'll wait for 5 seconds if someone wants to say that. Well, okay. I don't think anyone wants to hazard a guess. But basically, this ENT surgeon, why I've written here is that ENT surgeons are very fond of using colloidal iodine. I don't know where that concept has come in. It probably came in a long time ago when I was in medical college. Please remember, I was telling you, right, what are the causes of hypothyroidism? Excess of iodine can cause hypothyroidism. So there is no role of iodine supplementation in Maharashtra, especially in the areas where we live. Be very careful. Look at this case quickly. This is a 26-year-old primary gravida. She's come to a physician with thyroid report done. I'm presenting 3 scenarios. T4 is 5, TSH is 28. No question, she needs therapy. Another patient, T4 of 9, TSH of 6, borderline high. Does she require therapy? I told you, the only place where you will treat subclinical hypothyroidism is pregnancy and people who require thyroid. And here, although patient does not have history of thyroid disease in the family, does not have symptoms, but TSH is 6, I will still go ahead and treat it. And this is 4.2. I'm going to leave this for the moment. We will take it in question answers if this question arises. But here, remember that subclinical hypothyroidism, borderline TSH, go ahead and treat, because there are different things that affect both the mother with higher chances of hypertension and preeclampsia, impact on the fetus in development, both neurocognitive as well as physical development and low birth weight. And if the TSH is left very high, it will cause developmental delay, lowered IQ, and even deafness sometimes. So in frank hypothyroidism, please be aggressive on treatment. Now, this is a patient who is again a multigravida, who is routinely evaluated for thyroid in 16th week of gestation, has a normal FT4. The normal levels are up to 1.8, but her TSH is suppressed. Okay, so she has mild hyperthyroidism. Remember that in pregnancy, this is a very common occurrence. And particularly if the patient has morning sickness, you will often find this report. Do not rush in and give antithyroid drugs, because antithyroid drugs pass across the placenta and can cause fetal damage. So be very careful in treating borderline hyperthyroidism. I said the reverse for hypothyroidism. Borderline hypothyroidism, I will not ever blame if someone starts treatment. Borderline thyrotoxicosis, please wait. There is a different way of assessing these patients. What about an elderly lady with the same kind of thyroid level? Here, even if it is borderline, these patients require treatment, because as the age increases, if the TSH is so low, it causes atrial fibrillation at bone loss. So you might have to treat this. So I'm going to show you 2 quick cases of hyperthyroidism or thyrotoxicosis. One is a young girl, a definite family history, definitive symptoms. She has a definite goiter, and you will see that the T3 is grossly elevated, at least 2.5 times normal. T4 is grossly elevated, and the TSH is very low. She's a girl, she has a family history, she has goiter, and the T3, T4, TSH are elevated. Now look at another case, 38-year-old male. Again, thyroid levels were high, but no family history, no goiter, no proptosis, and mild, apart from tachycardia, there is not many symptoms. But on examination and inquiry, This patient has diffuse aches and pains, feels feverish, and when I examine this gentleman, there is marked tenderness on the thyroid bed. The thyroid tests were clearly suggestive of thyrotoxicosis, no doubt. But this is the giveaway. Tenderness on thyroid, systemic symptoms like aches, pains, and feverishness. What do we do in such situation? Here, we have two cases of thyrotoxicosis. One is a girl with family history. One is a young male, no family history, and marked tenderness on the thyroid bed. This is the place where we do a nuclear scan and a ESR. What are we looking at? We are looking at a typical hyperthyroidism on one side versus what we call viral inflammation of the thyroid and temporary thyroid leakage on the other hand. In this patient, the ESR was 100, typically suggestive of inflammation. In the first girl that we saw, the ESR was normal, and we did a thyroid scan. And this is a nuclear scan. For those who may not have seen a scan before, this is how a scan looks. This is the thyroid uptake, and this is the uptake in the salivary glands, the submandibular, the submental glands, and you will see a little bit of uptake in the gastric mucosa. This is a normal thyroid scan, okay? Look at the scan of the girl. This shows just uptake in the thyroid. You can see nothing in the background. No uptake in the salivaries, absolutely nothing in the gastric mucosa. This is because the gland is so hyperactive that it is picking up all the radio tracer and concentrating it. This is a typical hyperthyroid gland. Now, what about the gentleman where we suspected viral thyroiditis? See how it looks. You will see that the gastric mucosa is taking up some tracer, salivary are taking up tracer, but there is no uptake in the thyroid at all because this is not a hyperactive gland. This is a leaking gland. So it doesn't pick up the radio tracer. You understand? So this is not hyperthyroidism. This is something different. This is often treated with NSAIDs or glucocorticoids. And the first girl that we saw with this scan is treated with antithyroid agents. So always make the distinction between these two forms of thyrotoxicosis, the high uptake one, which requires antithyroid therapy, and the low uptake ones, which does not require antithyroid therapy. Let's go to the last case and then the last couple of slides and we'll wind up. So this is a 45-year-old woman. Look at the symptoms: decreased concentration, decreased libido, depressed mood, fatigue, diminished interest, sleep increases, weight is increasing, fatigue. And this very typically looks like the first case we saw, which was overtly hypothyroid. You remember the first one which I showed you. So, well, the physician said, yes, this is hypothyroidism. He did the test, and this was again repeated. The TSH is normal, the free T4 is normal. And what are we dealing with really? It looks like hypothyroidism, but the tests are normal. And remember, very, very important point is that depression looks the same as hypothyroid. And Lancet article, an editorial, says that 70% of people attending medical OPDs have some degree of depression. And I'm sure all of you who often take these emotive histories in such great detail know the importance of mood, of depression, cognitive imbalances. And basically, if you look at the signs that are all together, which are overlapping: constipation, appetite decrease, concentration, libido problems, delusions, depressed mood, diminished interest, weight gain, fatigue, increased sleepiness, are found exactly in depression also and hypothyroidism also. So in such patients, always consider depression as one of the most important diagnoses. Don't just say this is still hypothyroidism and I'll still go ahead and treat and keep testing them. Please be alert to this very important thing that could be seen. So I'll stop my presentation here because I want to actually, I want you to actually take this up now and start the discussion. So this can go on forever because there are so many other different aspects of thyroid disease. I cannot cover all of them today, obviously. So I said I'll just bring in some representative cases and take it ahead from there. So it's over to you, Abhay, now.
Yes, thank you very much, Dr.
Abhay, you're muted. Yeah.
So thank you very much, Dr. Uday. It was a wonderful learning. So let's have questions from the participants so that we can, understand this more. So I think Dr. Purti is raised her hand. She can go ahead and unmute herself and ask a question. Dr. Purti.
Yes, sir. You can hear me?
Yes, I can.
Yes, sir. Thank you for a wonderful presentation. Sir, I would just kindly ask you, I have a case of parathyroid adenoma, and she has plenty of, histopathologically, plenty of Hürthle cells. So do you think we should think of malignancy?
You said parathyroid adenoma?
Yeah, parathyroid adenoma, but the FNAC was done. And then they also saw in the thyroid Hürthle cells.
No, but why did you do an FNAC of the thyroid? And why did you do?
So the endocrinologist had done it. And
so when you say parathyroid adenoma,
yes,
what was the presentation of this patient?
So there was a lot of fatigue and the extreme fatigue, sir. She had already come with the diagnosis and the FNAC report. So she has both the things, like parathyroid adenoma and then...
No. See, when you have a parathyroid adenoma, did she have something like a hypercalcemia with elevated pH?
Serum calcium was 10.7 high. And sir, her parathyroid hormone has been about 77, I think.
So 10.7 is mildly abnormal. And
sir,
in such scenarios, especially if the patient is young and if she doesn't have any bone disease, I would just follow up this patient. Now, you cannot see Hürthle cells in a parathyroid. So I don't know where they picked up the tissue from and who did the FNAC. But this is something unusual. So was this actually the tissue picked up? So was this really a parathyroid adenoma, or did they actually see a thyroid nodule? That is the first thing to be questioned, because Hürthle cells will not come in a parathyroid adenoma. They will come in a thyroid nodule. It cannot come from parathyroid.
Correct. But I mean, they saw this in the thyroid. I think the adjacent tissue, they must have picked up both.
So, actually, I didn't go into thyroid nodules today.
Yes.
Thyroid nodule assessment is completely different. And there is a scoring system for risk assessment, which is called thyroid scoring.
Yes.
Now, if the patient doesn't have a thyroid nodule, just an incidental finding of few Hürthle cells, I would just follow up this patient with ultrasound every few months to find out if something is happening. But clearly, I would like to examine this patient because I cannot understand how Hürthle cells came from a normal thyroid tissue. Of course, some tissues may have some Hürthle cells, but this is, the FNAC was meant for parathyroid. Actually, we don't do parathyroid FNACs, honestly. The diagnosis is biochemical. So I think there is some confusion here. And clearly, I think this patient should be reassessed. Very definitely.
So I cannot offer an opinion. Blood investigations to rule out malignancy. I mean, that's a separate
No, there are no blood investigations to rule out malignancy. Okay. Malignancy diagnosis is based very definitely on ultrasound scorings, clinical history, and fine needle aspiration of the thyroid. And there is a system for scoring FNACs of thyroid, which is called Bethesda system. And there are separate grades from 1 to 6, starting completely benign to malignant. And then they are assessed. So just a few Hürthle cell in some non-specific area doesn't mean much. I would just keep this patient under observation.
Okay, so thank you so much, sir. There's one more question. I'm so sorry. Second question. If the TSH is normal and if the T4 or the T3 are abnormally low, what do you conclude, sir?
So then see, as I was saying, it's good that you raised this topic actually. So this particular area I did not address There
Yes.
are differentials here. So normally when you have a low T4, the TSH automatically has to go high,
Yes.
right? If it is not going high, either it is a binding protein abnormality, which means I told you about the thyroid binding globulin.
Yes, sir.
So T4 being low, you must check for TBG. So we don't do TBG, we do a free T4.
Okay.
If free T4 is normal
Yeah.
and TSH obviously is normal, leave the patient alone.
Okay.
If free T4 is also low, then
Yes.
you're dealing with a pituitary defect and not a
Okay.
thyroid defect.
Correct.
Because
Right.
so it's a central hypothyroidism. I didn't really go into that.
Yes.
And the last thing is something called sick euthyroid syndrome. So if you assess a patient when admitted with serious disorders, which are
Yes.
non-thyroid, it could be just septicemia, you will
Okay.
often find that the T3, T4 are very low and the TSH is not elevated. So that's a separate entity to be considered. But do a FT4. If FT4 is normal, leave the patient alone.
Okay. Thank you so much, sir. Thanks for your guidance.
Okay. Another question, another person has raised her hand is Dr. Mugdha, I believe. So Dr. Mugdha, please go ahead and ask your question.
Yeah, good evening, sir.
Yes.
So I have two questions. One is you said that if the lab reports, there are different lab reports which give you different ranges for TSH values or the hormonal values which are given. And you said that a person, if the range is up to say 4 or something, and you said that range should be maintained between 0.5 to 2.
Or 2.5.
Yeah. So if it is around 3 or less than 5.
Yeah.
Yeah. But some people still continue to have symptoms of tiredness, sluggishness, even though it falls in the normal range.
So that's what I told you, right? So then don't blame the thyroid. Look for something else.
No, so
It's
there
not
was
because of
one, I have a friend also who is an endocrinologist,
Mhm.
and her opinion was that if you continue to have symptoms of tiredness or sluggishness, and even if your range, I mean your TSH continues to remain in that normal range, it means the dose which you have been given is not optimum. You need to step up the dose and go to the TSH needs to come down a little lower to give you more energy or something like that.
See,
So is that true?
you can try bringing the TSH down to 0.5 to 2 to 2.5. But remember that if the TSH instead of 2.5 is 3.5, you cannot have fatigue. Again, I'm giving the corollary of, say, blood sugar. If 100 is normal, if your blood sugar is 104, will it cause weight loss and severe fatigue? No. It's the same thing. So don't blame thyroid for everything.
Okay.
You may attempt to bring it down to 2.5, but between 3.5 and 2.5. See, when I say 2.5, in the community, you will have a range of 0.5 to 4, and sometimes even more. There are always outliers. Not everyone is between 0.5 to 2.5. For the sake of uniformity, we try and keep it between 0.5 and 2.5. This is absolutely optimal. But 3.5 with severe fatigue, no way. No way this is thyroid. You'll have to look for something else.
Okay. Thank you, sir.
We're missing something there.
Okay. So the next question which I have is that all of us are seeing so many cases of hypothyroidism. It's almost become like an epidemic globally. So what is your opinion? Is it something to do with today's lifestyle, or it's just being diagnosed much more than what it used to be?
Well, that's an excellent question. Certainly it is being diagnosed more because practically everyone is getting a thyroid test done one way or the other for some reason or the other, number one. Number two is, yes, autoimmune disorders, particularly of the thyroid, are on the rise. There could be several things responsible. Some people feel that there are some triggers which set up autoimmunity. These could be environmental triggers like pollution, what we call endocrine disruptors. So many fertilizers, chemicals, cosmetics, food additives that we use sometimes can set up autoimmune processes. We don't know what they are, so it's very difficult to point to one. But we have this is a discussion that often occurs in our meetings, and these are called endocrine disruptors. So that's one reason. And the other reason is excess of iodine that we are exposed to. So normally, if you stay in Pune or nearabouts, our water contains good amount of iodine. And with iodination of salt, which was started for a very noble idea that we should be preventing cretinism and mental retardation, that means that everyone who doesn't even need iodine is still getting iodinated salt. And that has been considered as one of the factors which might increase the incidence of thyroid disorders. But let me tell you that this is not proven. It is a concept, it's a hypothesis. So don't stop using iodinated salt.
So a lot of people are using this Senda salt or...
Yes. Well, I don't stop them from using it because it's fine. You don't need the additional iodine in the salt anyway. Your water contains adequate iodine.
Thank you, sir.
But you're right, the autoimmune disorders of thyroid are clearly increasing. And you will find a similar trend in other autoimmune disorders, let's say like type 1 diabetes, which was not very common in India, but now we increasingly see type 1 diabetics more commonly.
Yes. Okay, thank you. So we have Dr. Varsha Shah. Can you please unmute yourself and ask the question?
Dr. Shah, you're not audible properly.
We can't hear you.
Thyroiditis and migraine has any relation, sir?
Thyroiditis and?
Migraine.
Migraine?
Huh.
No, there is no specific correlation between the two. I mean, hyperthyroidism, because of a hyperdynamic circulation, can precipitate migraine. But as such, there is no specific correlation between migraine and thyroid disorders as such. Not really.
Thank you, sir.
Dr. Sameer Jindal also has one question. Please go ahead, Dr. Sameer.
Good evening, sir. Sir, one 25-year-old female, she has come with thyrotoxicosis and she is to get married next year and then she has to start a family. So given this history, what could be the best choice for treatment? Because she was advised for radioactive iodine therapy.
Yes. So I'll tell you what the logic is. The logic is that hyperthyroidism often does not remit in India or doesn't go into natural remission in India, despite using antithyroid therapy for say 1.5 years. And then after 1 year, she gets married and she becomes pregnant. Her fetus is being exposed to antithyroid drugs. Now, antithyroid drugs theoretically have some chances of problems in organogenesis, and they cause two important disorders. One is aplasia cutis. The second one is called choanal hypoplasia, which basically involves abnormalities of development of the nasal cavities. Now, these are not common, but you can't predict who will get them. So what we suggest to these patients is to undergo radioactive iodine, become hypothyroid, go on to thyroxine, because thyroxine is completely safe in pregnancy. So much before they contemplate pregnancy, we convert them into hypothyroidism and treat it because it's much easier to treat and safer for the baby. That's the logic.
Okay, sir. So, and one more question. One of my patients, she was having TSH of 6.5, but she did not have any symptoms. So I continued on my medicines. I gave homeopathic medicines, but then she missed her periods and then she was UPT positive.
Okay.
So I asked her to visit an endocrinologist and start with the required dosage of thyroxine.
Yes.
But how much is it? What should be the exact time to start? Because this time we did not know that she would be pregnant. So initial part of say 2 weeks or something of pregnancy, she has not taken.
I understand. So there are two options here, two aspects to this. As I said, a person who is planning for pregnancy. So she came to you planning for pregnancy. You knew that she would get pregnant in the near future. In such scenarios, borderline TSH is better to be treated. because then you don't come across this scenario where she already gets pregnant and then you start worrying what will happen.
Right.
But nevertheless, even if she comes to you with TSH of 6.5 after having conceived, don't worry. The recommendation is to just start treatment and make her euthyroid as soon as possible. Don't worry. Nothing will happen. Just start treatment right away and get her to normal as soon as possible. We don't recommend termination of pregnancy in such scenarios.
And any early anomalies can...
Hypothyroidism doesn't cause anomalies. If you leave the hypothyroidism untreated, it can have consequences for the mother and the fetus. But if we treat her in time, no problems.
Fine. Thank you, sir.
Okay. So Dr. Manisha Khare also has raised her hand. Kindly, Manisha, please go ahead and ask your question. We are now...
Yeah, thank you, Abhay, and thank you, sir, for a really helpful presentation. What I would like to just know is what is the role of supplementation, like the calcium supplements or other supplements, to reduce the inflammation in the cases of thyroid?
So calcium is not an anti-inflammatory agent. So by and large, so calcium supplementation in thyroid disease, there is no relationship between the two. If you look at the Indian population, adults would require an average elemental calcium of about 1 gram every day to stay healthy. If you look at the figures available, the average intake of an Indian in terms of calcium is approximately 400 milligrams. This is for people who do not consume large amounts of dairy. So if you're consuming large amounts of dairy, you don't need calcium. But if you're not, anybody and everybody can take a pill which contains about 500 milligrams of elemental calcium, and there is no harm in it. But the concept that if you're on thyroid therapy, the bones are eaten off is absolutely false.
Okay.
That is the answer.
And regarding, sir, increased dairy intake, nowadays there is a trend like not to have milk because of the hormones given to the cows.
Yeah, so exactly. So that's the problem. So that's why, as I said, anybody and everybody can have a calcium without monitoring much, because even by just giving 500 milligrams of elemental calcium, you'll never exceed the standard recommended daily allowance. So it's no problem if everyone takes a calcium pill every day.
Okay. And what about the anti-inflammatory supplements or supplements like omega-3, or which is the trend?
No, there is no role. Absolutely no role.
Okay.
Absolutely no role.
Okay. And the restriction about having soya in the food?
I told you, right? There are no dietary restrictions in the amount that we eat normally.
Okay. Yes. Thank you so much, sir. Thank you.
Yeah.
So we are running short of time now. So maybe I can just say that maybe one or two more questions. Dr. Shraddha, please go ahead and ask your question. And then Dr.
Yeah, thank you, sir. Sir, I have seen 2 or 3 cases where the patient's main complaint was anxiety, and especially at night time, and claustrophobia. So the patient was visiting doctor after doctor, counselor, psychologist, and and accidentally it happened that 2 patients, similar complaints, they happened to be diagnosed with the thyroid. So was that just a coincidence,
so thyroid
or
means
this
what?
is
Were they
one more symptom
thyrotoxic?
we can...
So were they hypothyroid? Or... So
Yeah, sir.
they were hypothyroid.
Hypothyroid, yeah.
And what was their TSH, if you recall?
I do not recall it, sir. It happened in past, but I only remember.
So it does happen that people with undiagnosed hypothyroidism may have mood disorders also, and can present with some degree of depression and anxiety. So it is good to check for TSH in such individuals. So you're right, there is some role of thyroid playing an abnormality in these situations.
Okay, because sir, typically they had claustrophobia, anxiety, and difficulty in sleeping in small room,
You know what? Claustrophobia is not associated with anything. Claustrophobia is a pure phobia. It's an anxiety disorder and needs to be looked at separately. But yes, untreated hypothyroidism may have certain mood or cognitive disorders, and we should look at TSH in such patients if no other cause is found.
Okay. Thank you. Thank you. So I think now we can go for one more question only. Dr. Kanika, can you please go ahead and ask your question, please?
Yes, thank you. Good evening, sir. Thank you so much for this session. I actually just wanted to ask you, going ahead from the point that you spoke about during your presentation as regards the maintenance therapy, you said that if a person is coming during follow-up treatment, if their TSH continues to be normal, one should continue the same dosage and not think of tapering or stopping. So I just wanted to ask, is there a protocol as to how many months or how many years that would continue? Because I'm a homeopathic doctor, and if I'm giving homeopathy, if the person is asymptomatic, is there a time frame after which I can consider tapering down, or what was your recommendation? If you could just elaborate a little more on that, please.
So, as far as from my perspective, we never discontinue thyroxine doses. Now, there are rare situations in which natural remission does occur in thyroid, but this is an autoimmune disorder.
Right.
So that, for example, rheumatoid arthritis can go into remission, ulcerative colitis can go into remission. Similarly, hypothyroidism can go into remission. But remember what I said, that the TSH is an extraordinarily sensitive test. So even if I give 12.5 micrograms to a person who doesn't need it, the TSH will be abnormal. So the very fact that TSH is normal means that the patient requires that dose. If I see consistently low TSH while on therapy, then I can reduce the dose, not otherwise.
All right. Okay. Got it. Thank you so much. Thank you.
Sure.
Yeah, okay. So the last question absolutely from Dr. Varsha Shah. And then we close.
Sir, with thyroiditis, cervical lymphadenopathy is it a correlation or anything related to that?
So basically, I don't know what you exactly mean by thyroiditis, but a number of...
It is a autoimmune thyroiditis, sir.
Autoimmune thyroiditis, yes. So autoimmune thyroiditis will often have some degree of reactive lymphadenopathy, and that tends to go away once you start thyroxine. It need not be looked at. However, if there is significant lymphadenopathy along with a nodule inside the thyroid, one needs to be alert about the possibilities of malignancy with metastasis or lymphoma of the thyroid. Now, lymphoma is an extremely rare disorder, but if you're seeing very large cervical lymph nodes which are not regressing with therapy, be a little careful. The mild subclinical ones will disappear with therapy, and that there is no problem.
Okay. So I think we've had a wonderful session, and it was really very interactive, and Dr. Uday has really answered a lot of queries, and we look forward to this association, and maybe we can have one more or two more sessions where we can discuss things like PCOD and, infertility and things like that, and how to manage or how to understand the hormonal levels during that time. So we look forward to that. And I would also like to tell all the participants that we will keep on having these kind of webinars, where we want to integrate this knowledge of clinical knowledge and our, diagnostic techniques, etc., etc. So please look forward for many such webinars from our end. And at the end, I would like to thank all the participants for their active participation, and especially Dr. Uday Phadke for sparing time from his busy schedule and, honoring our request and doing this wonderful session. Thank you, Dr.
My pleasure, Dr. Abhay. Thank you for the invitation, and good night, everyone.
Thank you and good night.